Welcome to today's Community Roundtable, Current State HL7 Da Vinci Implementation Guide Progress in 2022. My name is Alex Goss, and it is my pleasure to moderate today's presentation and to remind all of us that we engage in these forums under HL7 antitrust policies to ensure appropriate collaboration and information sharing. We are grateful for your participation in the October Community Roundtable, Da Vinci's educational webinar. Our agenda includes a brief update on news and key events before our main event. Today, we have Da Vinci use case leads and project manager to deliver firsthand accounts of the material updates and changes made in 2022 across Da Vinci Implementation Guides and begin to look forward to 2023. Presenters will highlight implementation guide functional additions, the status and the phase of the guides to help inform your planning for next year's FHIR implementation staffing and allocations. Today's presenters are Vanessa Candelora, HL7's project manager, HL7 Da Vinci's project manager, Dave DeGandi, burden reduction co-lead and attribution co-lead, Christol Green, who's also joining me on camera at the moment, who may want to turn off her camera till we get to that appropriate portion. And if you could turn it off, I'd appreciate that because it'll leave a black spot on the screen throughout the presentation. Thank you, Christol. Christol Green is an active participant within the Da Vinci project and also our clinical data exchange co-lead. Linda Michaelsen, the Data Exchange for Quality members co-lead, will also be joining us today. In addition to our deep appreciation of these individuals sharing their knowledge and dedication to being a use case leader, we are grateful for their organizational support to do so. So thank you also to Cambia Health Solutions, Elevance Health, and Optum. A bit of housekeeping for all of us today. Please use the questions menu to support your ability to submit a question. We will be taking a Q&A after our presentation. We expect to allow at least about 15 minutes for that at the end. So please put in your questions as we go. Also, if you're having any audio issues, you may want to dial into the session via the number provided in your registration. If you're encountering sound issues, you can also leave and come back into the webinar. That can also resolve them if you're having bandwidth issues. We also have a survey at the end that will launch at the end of the webinar, and appreciate your feedback as we take it very seriously and factor it into our programming efforts. So now let's move on to a little bit of the community roundtable schedule. So this is our final webinar for 2022. It'll be on the 5th Wednesday, November 30th is our final roundtable for the 2022 calendar year. On the 5th Wednesday, it's a bit off cycle. And for our Da Vinci membership, please note that we will be combining our monthly meeting with the community roundtable in November. So we've blended the two meetings to be efficient in sharing the Da Vinci 2023 priorities in year-end review as informed by our recent survey of Da Vinci members and solidified through the Da Vinci governance process. We'll then take a hiatus in December with the intent to return to normal programming in late January 2023. Staying informed is easy through the Da Vinci listserv, so we encourage you to sign up for the listserv for meeting announcements and other key details pushed out to subscribers. All right, so let's now talk about events. So in VIVE, some of you may have heard about the VIVE conference from last year. It'll be March 26th to 29th and in Nashville. And I'm getting a bit of a background noise, so if you could mute yourself, panelists, I greatly appreciate that. We'll have the HIMSS conference in 2023 that we plan to participate in from April 17th to 21st in Chicago. And in finishing out this year, we wanted to make sure you were aware of the October 31st to November 3rd NCQA Health Innovation Summit in Washington, D.C. As to the upcoming HL7 testing events and working group meetings, you can join us at the Hilton Hotel Lake, Las Vegas Resort and Spa in Henderson, Nevada from January 14th to the 15th for the Connectathon, or you can join us also for the January 16th to 20th working group meeting. Some other news we'd like to highlight. I'll be covering 3 items here. First one is a request for information on advanced explanation of benefits and good faith estimates for covered individuals. This is an RFI that was released in mid-September by 3 agencies and seeking information on transferring data from providers and facilities to plans, issuers, and carriers, and other policy approaches and economic impacts of implementing the requirements to share good faith estimates with patients. So it calls out the release the release calls out for the potential for using FHIR, APIs, and the efforts from our HL7 Da Vinci patient cost transparency use case. Hopefully you'll take the time to look at that and submit comments by the due date of November 15th. An additional request for information has been released since we last met. October 7th, an RFI was released by CMS, seeking input on the concept of CMS creating a healthcare directory with information on healthcare providers and services, or what they're calling a national healthcare directory of healthcare providers and services. We've included not only a link to the RFI, but also the press release in these slides, which will be posted along with a recording of this event tomorrow morning. The RFI is an opportunity for you to weigh in on the concept and potential benefits from a centralized data hub and other aspects that CMS has included within that RFI. Comments are due December 6th. The Da Vinci community will be participating with our fellow accelerators in advancing a response and submission into the CMS process. Stay tuned for more details through our listserv. And finally, I would like to make an exciting announcement related to a pre-authorization innovation announcement that was just released through the collaboration of Regents partners with Multicare regarding their use of the pre-authorization processes that are enabled through our coverage requirements discovery, document templates, roles, and prior authorization related resources and implementation guide. Encourage you to take a look at that exciting news and their deployment experiences, and hope that if you have similar press releases or articles regarding your work, that you would share them with us so that we can then further share and promote your successes using Da Vinci Implementation Guides. Without further ado, I'm going to invite Vanessa Candelora, the HL7 Da Vinci project manager, to come on screen and become the new presenter and walk us through today's exciting content. Thank you, Vanessa.
Thank you so much, Alex. All right, can you see my screen where it says current state?
We can.
Yes.
Perfect. Awesome.
Thank you.
Excuse me.
Great.
Great. Thank you so much, Alex, and thanks everyone for joining. As Alex said, this month, we are really excited to share the great work of the Da Vinci community that many of you all have played a role in. So we have 2 main sections to go forward after the great information that Alex just shared that Dave, Christol, Linda, and I are going to be sharing. First, I'm going to provide some updates regarding our recently completed Da Vinci member survey that will act as a precursor a little bit to next month's community roundtable that Alex mentioned, where we'll look forward to next year for Da Vinci activities and focus. But secondly, you will hear from our Da Vinci members, Dave, Christol, and Linda, who are named on the screen here, to share a current status update of all of the amazing work that they have been doing, co-leading these use cases with the communities that we've been building, and share key accomplishments this year, what's on the horizon a little bit, again, a teaser for next month, and how to get involved at that use case community level. So we are very excited for this community roundtable. Okay, So Da Vinci survey member results. Since the start of this project, we've actually been doing a member survey. We didn't do one last year because of COVID and there was a lot of busy times, but we did one this year. We received great feedback from members, really rich content. And the biggest takeaway was really people's support for the project, and that building standards is how people really want to get work done to deliver within their organization. So they're really moving from thinking to implementation, and the funding is happening for the work within the organizations. We were surprised at the level of interest for wanting to support and lead at the use case level, new use cases in coming years. So there's definitely more to come on that. When we asked, what could we do better? One thing was greater visibility into getting test feedback and a real desire to find partners for use cases. So we're working on creating a transparency way to enable people to share what they're working on and connect with each other with contact information. Next thing to work on was to evolve our storytelling, to share what problems are being solved at a business level with the use cases that we're working on. And another one was we gave members the opportunity to say, hey, just keep doing what you're doing, lower my price, and continue sort of lifestyle like, right? Or let's do more, let's grow. And overwhelmingly, we heard people wanting to do more, and also to make it easier for new members to join Da Vinci. So I am excited about that. And then the members actually gave permission to share this really powerful visual publicly, which we're excited about. So what you're seeing here is Da Vinci members' commitment to implementation across 15 different use case opportunities that are out there and available. So if you look at the graph, the bar, just to orient everyone, the red is adopted, the gray in the middle is adopting in process, and then the brown over on the right is planning to adopt. And naturally, the IGs that were named or referenced in federal regulation have the highest adoption, and the smaller bars are the newest IGs that have really strong individual community support, and we expect that that will gain adoption and interest throughout its sort of typical life cycle of a use case. We were super impressed with the brown sort of right-hand band that people are planning to adopt across a number of these use cases, pretty much all of them. And it was really cool to especially see CDEX, the Clinical Data Exchange. I don't know if you can see my mouse, but I've got it right over here. And so we were really excited to see that as the third highest committed for adoption. And so we included a slide on CDEX, and you'll hear more from Christol in a few minutes. But CDEX has really matured a lot over the last few years. So thank you to those of you that were involved in that use case. We wanted to call out that on the survey, we actually asked some really specific questions about building additional scenarios to support the multitude of ways that CDEX can actually be leveraged to improve clinical data exchange. There's, a few of them listed here on the slide, but there's a real opportunity to improve care with additional clinical data exchange. And, in our survey, no one said, no, this is not worth the effort. All of the responses were yes or not sure. So we have compelling interest to build out more user scenarios, and really look forward to collaborating with the community at CDEX within our weekly calls, but also at Connectathons and next year to further advance CDEX and the storytelling that goes on there. So we hope that you join us in an upcoming Connectathon, particularly in January, or at other events, or get involved with CDEX. And you'll hear more about sort of where we are in that process from Christol in a few more slides. So this is an updated slide of our membership as we close out the year. First of all, thank you so much to all of the Da Vinci members that have contributed to this project. You'll hear Jocelyn and others say over and over again that this project is fundamentally a human-powered endeavor, and it really is. We continue to be very fortunate with strong support across the industry, so we're just so thankful for that. And industry partners continue to be very important to us as well. The funds that folks contribute, along with the in-kind people resources, which are more and more actually fueling the day-to-day leadership of our use cases, but that's really how the work gets done. And so funded resources are how the IGs get built and validated with test scripts and reference implementations, and that's proven to be a really successful model. So we wanted to share a little bit more about becoming a Da Vinci member. We often get questions about that this time of year. I'll remind folks that you don't need to be a member to contribute to this work. But here is just a slide on some basic information about what those different levels of becoming a Da Vinci member look like. So we simplified our membership model a little bit to make it more accessible and also align more closely with other accelerators. So we're really happy about this simplification. We still maintain a focus on trying to add underrepresented groups within our membership, so specifically the multi-specialty and independent providers, more EHRs or provider vendor partners, and small regional or and Medicare, Medicaid health plans. And so we'll talk a little bit more about membership in future meetings, but we wanted to just share this grid as we're actively taking new members between now and the end of the year. And we know that some of you may have budgeted funds that you're trying to use up by year end. So if you're interested in becoming a funded or sponsored member of Da Vinci, even next year, send an email to the davincipmo@pocp.com, and we can make sure that gets put in the chat if not already. It's davincipmo@pocp.com. All right, and so now for the second portion of our presentation today, we're going to dive into our use case community happenings, and we're looking ahead at 2023, and we want to just help folks understand that what we're really doing here is building communities, the tools, storytelling, and communication methods to support thriving communities for each of our use cases. And we work together to figure out what we need to get feedback from each other and drive this innovation, and each use case is really building its own individual community within the greater Da Vinci and HL7 community. So it's very exciting. All right, this is a slide that many of you have seen before, but there's a new addition. So our value-based performance reporting use case went public with public meetings last month, which we're really excited about. And there was a great overview by my colleague Teresa Yonkin and Samira and Vincent at Providence and Heather Kennedy last month at the September Community Roundtable, which you can of course get the recording from Confluence on. But I wanted to reinforce this visual a little bit in that it is very rich in information. And so you'll see all of these dials on the subsequent slides that me and the member colleagues that are joining me will discuss. The colors of each of these dials represent the overall readiness scale calculated with several inputs, one being the HL7 Standards Development Maturity Model, another being regulatory drivers, and also real-world adoption. And so that's what the colors of the dial mean. The dials themselves, meaning where they're pointing, is pointing to progress within the phase of the project. So like development toward a ballot, or ballot reconciliation progress towards publishing a new version of the IG. So that's sort of what that dial means. And then lastly, the asterisks down here and the diamond, they reference support or alignment with existing or expected federal regulations. So we note those next to the name of each of the dials here as well. There's a few use cases on here that we are not going to dive deeper into today, so I want to just mention them briefly here before we turn it over into the specifics on the subsequent slides. The foundational guides for health record exchange, HREX. that was published in March of this year, 2022, and it's referenced by many other IGs, which you'll see noted or linked to from some of the subsequent slides. It's a foundational guide, so there's no reference implementation, but we did make a lot of updates to it, and we continue to take feedback from it from some of the other use case groups. Notifications is another one down here under foundational assets. So notifications has been published for quite some time. We are always open to hearing from the community on if and when we want to advance this guide further. We've kept an eye on subscriptions and have kind of been looking at that subscriptions model for maturing with R5. It was published with FHIR R4B, and there's actually some discussion of adoption of it within R4. So there's opportunity there. We love to hear from the community on this IG. It's really about a defined format for sending unsolicited notifications to appropriate actors triggered by an event or request with just enough information to understand what it's about and know if action is needed. So it's a really great IG. A lot of early adopters have taken advantage of it and continue to do so. So if you're interested in that, you can join us. Their monthly calls the first Wednesday of every month for notifications. I'll just briefly mention our PDEX formulary right here and PDEX PlanNet or directory. Those guides are distinct implementation guides that are under the umbrella of PDEX, and they both had publications this year. Christol's going to mention them a little bit more when we get to the PDEX slide, but we just want to take a minute to thank all of you that contributed to those implementation guides this year and use cases, and we hope to see you at Connectathon. Formulary will be part of the PDEX track, and there is a new version that had some really great structural changes, pretty significant changes this year in the STU2 version. So if you haven't looked at it in a while, we encourage you to pick it up and see if you're interested in implementing and testing that and joining us in January. And also the PlanNet directory track, PlanNet directory use case will be part of the FAST national directory track, most likely in January. And so we encourage you to participate in that as well for testing that guide that was published with an STU update in the spring. Okay. So now, as promised, I'm just going to do a quick overview of what the slides to come are, because you'll see a similar format on all of them. So we'll hear from the Da Vinci members and me that are actively co-leading use cases. But each of the following slides are going to show you a few different areas. So you'll have an IG snapshot, which is that same dial that you're looking at right now. And a summary of the use case that you may have seen before, just to orient to what the goal and the purpose is of the IG. Then you'll see what's changed in 2022, which highlights some of the key accomplishments that these individual communities have achieved this year, which is pretty phenomenal. Then how you can get involved based on what's currently happening on the ground within these use cases. And also looking ahead, a little bit of a teaser of what's to come at the use case level, and there'll be more roadmaps in November. And then lastly, we included links on all of the pages to make it easy to find the Confluence pages for that use case, the most relevant version of the IG based on the current phase of work that it's in, and also a reference to the supporting IGs. So without further ado, I will turn it over to our dear Dave DeGandi for member attribution overview. So Dave, if you want to come on screen and take it over whenever you're ready.
Sure, thank you. Dear David, I've never been called that before. Thank you. Member attribution. So as it says here on the slide, it provides an ability for the trading partners to validate member or patient lists to ensure that they're working with the right population set. The lists are exchanged between payers and providers, and supporting the value-based contracts, care gap closures, quality reporting, aligning on patient list is a foundational operating in a population mode for those other IGs I just mentioned. So the getting involved, testing, it'd be great to have some testers. We're doing Connectathon in January. And coming out of your testing, we'd like to hear some some comments. We have STU2 will be going to ballot in January. So what we've changed over the last year is the ability to reconcile the patient lists, where you can do add, update, and delete from a list automatically using API calls. And a lot of the other use cases like gaps in care, risk adjustments, and PDEX, payer data exchange, were originally written for an individual aspect. And by incorporating the patient list, we can now function in a for population mode, like I said, and we've been making accommodations within member attribution to allow that to happen and make sure that we're carrying the right data needed for those use cases. The reconciliation aspect is also in alignment with the CMS, DPC, and BCDA programs. Looking ahead, we're going to ballot in 2023 with our version 2. We'll get some more testing, and once we get more mature with the STU2, we'll be moving that into HREX as a foundational tool, as it is turning out to be more of a tool than an individual use case. And we're open to providing guidance to implementers as needed. Next slide, please. Coverage requirements discovery. This is the first of 3 burden reduction prior authorization use cases. It's really enabling the ability to ask, is authorization required for this service? And any advice that the payer could give to the provider user on how to best manage the patient's care. We've been engaged in ballot reconciliation for quite some time, looking to go to ballot, I believe, in January, or resolve our tickets by January. Any content that's been updated in the most recent version is highlighted in the implementation guide. It makes it easy to find. And I provided some links here that will give you a link to the actual changes. And some examples of those changes are challenges where CRD is introducing sending of SNOMED code, which payers don't normally know what to do very much with SNOMED codes, and they prefer CPD codes. So there'll be some work there on how to manage that. So this is one of the use cases referenced in the 9123 rule that's coming out. I don't know the exact date it's coming out, but it's coming out. We're going to continue with ballot reconciliation, helping people implement, and can't test this stuff too much. Appreciate the help and making sure we get a good product. Next slide, please. Documentation templates and rules. It's basically in sync with the CRD use case as far as where we're at on the reconciliation and balloting process. We're doing ballot reconciliation with DTR. There's a more complexity, I would say, to DTR as the variations on medical necessity evidence and policy enforcement are many. We've tried to improve the user workflow functionality, where we're allowing the saving of a session, so a provider could come in and at a later time and complete a request that they'd originally started without having to start over. And there's also some performance requirements and different aspects. There's a link there for the changes for STU2. I'll give you a summarized list. Again, this is referenced in the rulemaking from CMS that's coming out. And testing. Let's help people get this in. We do have this running in production at Cambia with our vendor partner MCG. And it's taken, I think, a mere 4 years to get it there, but we're there. Next slide, please. Prior authorization support, this is the final step in the burden reduction. It's actually sending the request for authorization to the payer. But what's changed in this use case, so organizations have implemented. Da Vinci's also sponsored a CMS exception, which in our implementation we're taking advantage of, where we don't have to do the 278 translation. We're doing direct FHIR to FHIR, and Da Vinci members are eligible to qualify for that exception request. There's also quite a bit of focus on this from the ONC through their HITAC organization and a special task force around electronic prior authorizations. There's some links here that I've added that will point you to that content where that study was done on certification requirements, and that's something new to payers, certifying for prior authorization. But it's required to make things really scalable in this interoperability world, make sure people are conforming to the standard properly. And same comments I had on the other two, referencing the NPRM, working on ballot reconciliation. Welcome to join us. We have calls on the HL7 call site every week. There's a few of them. Any help we can give implementers, we're happy to do that. And I will pass the torch.
Thanks, Dave. Awesome. I think that all the work that the CRD, DTR, and PAS teams have been doing, just in everything you mentioned with what's happening in the regulatory space, what's been going on in the weekly calls. There are a lot of calls for the public community. There's a call Wednesday, Thursday, and Friday that are focused on CRD, DTR, and PAS. The PAS call on Thursdays is the newest. It just started up earlier this month, maybe last month. And so, we encourage you to get involved in the ballot reconciliation that's going on those calls as we work towards applying all the changes and feedback we heard from the community and move towards publication of all three of those guides. So really excited about the activity happening there. We do expect to see that rulemaking coming, at which point we will evaluate what additional changes need to be made. So it's a really good time to get involved there. We have a really great community in what we call the Burden Reduction Guide, CRD, DTR, and PAS, as Dave was mentioning, and we're seeing real-world implementation to the news. Congratulations, Cambia and the team and everybody that Alex mentioned earlier in this call. So really exciting stuff there. We hope you get involved. And now I'll give a quick update on patient cost transparency. So patient cost transparency is a guide that we are, in our dial sort of marching towards publication, working to wrap up our ballot reconciliation. So what this guide supports is the exchange of data and information from providers to payers for a good faith estimate, and then payers out an advanced explanation of benefit to patients, and also optionally back to the provider. And that is all in support of the No Surprises Act, which is part of the Consolidated Appropriations Act, which is a law that we're looking to see regulation coming eminently on enforcement and implementation details of. And so Alex actually mentioned earlier in the call the RFI that was put out by the tri-agencies. So there's a lot of activity happening in this use case community as well. What we've accomplished this year, so we completed a January cycle HL7 ballot this year, and since then we received over 200 comments on that ballot. So we've done a lot of work this year, updating profiles, operations, and aligning workflow, and working with the community as business workflows were figured out to support this new concept of cost transparency. Not that cost transparency is new, but that the workflow to support the No Surprises Act pieces are new. I should really clarify there. So we have worked very hard to balance alignment with claim submission standards and also what the minimum known data is at the time of scheduling for provider to payer good faith estimates, to try to balance those needs in the industry for estimates, knowing that there's a lot of information that we don't know, and we want to try to reduce the burden to implementation. We defined must support, which took us a long time. If you're involved in those Friday calls, we spent many hours talking through how to define must support within the patient cost transparency guide. We leveraged and defined many code systems and value sets to support a centralized management within HL7 called THO, or HL7 terminology inclusion. Updated a lot of invariants, which are like rules to drive standard requirements to try to meet the goals of creating a standard for this data exchange for cost information. We did a really good overhaul to our overview section in the guide, and are still in the process of updating some of our graphics based on feedback to try to make them more clear and to make the scope of this guide really clear. We got a lot of questions early on about the IG relationship to regulation or pending regulation, to X12 standards for claims, even though this is a kind of like a predetermination, as well as business workflow decisions. And so we've done a lot of clarifying around those areas, more prose work as well. So join us at the January Connect-a-thon, where we are always looking for partners to test against the RI, to test against some of the other participants that come, read and review as we work towards finalizing our guide for publication. We're down to about 25 or so tickets or comments that remain for public review. And we encourage you to start adopting and picking up the guide so we can learn from that feedback and you can take advantage of it as this regulation landscape carries on. We'll continue looking ahead to updating the workflow for some of those non-happy paths, so errors or things that come up when it doesn't go well with the good faith estimate submission, and also leveraging that patient access API for patients to be able to retrieve their advanced explanation of benefits from payers, all within that same patient access that a lot of payers invested in heavily last year for the July enforcement. We're looking to publish our STU1, Standard for Trial Use 1 of Patient Cost Transparency. We're expecting regulation, as I mentioned, and then we're looking straight on to phase 2, which likely will include the gathering of good faith estimate across providers and working through what that workflow or workflows could look like and how that data needs to be exchanged in order to get one cohesive advanced explanation of benefit to a patient for services that are including multiple billing providers. So very big challenge in the industry that people have been talking about for quite some time. We included links to the Confluence page, to our continuous integration build, which is going to be the version of the implementation guide that has all of the new updates in it that we've been making this year from the balloted version that was sort of stamped as a snapshot for ballot December of last year, maybe even November before the January ballot. And then also a link to the technical background and underlying technologies like US Core and FHIR to an HREX that support this guide. So that is patient cost transparency. If you want to join our weekly calls, we meet on Fridays at 11 a.m. Eastern time for 2 hours every week. So we hope you join us. And with that, I will turn it over to Christol Green if you want to join me on camera for a CDEX update.
Thanks, Vanessa.
Yeah.
Can you hear me?
Yeah,
okay.
You sound good.
Well, good afternoon, everyone. I will be covering the CDEX and the PDEX slides today. So starting with clinical data exchange, this enables providers and payers to share key clinical and administrative data for their patients using either a direct query or a task-based approach. Some of the key scenarios that we have been testing, we exchanging data between referring providers, requesting attachments to support a claim submission, for medical necessity or other reasons, gathering additional information or quality programs, risk adjustment. We also have the process of sending attachments from a provider for claims and prior authorization transactions. And it also supports digital signature with this clinical data exchange. I'm going to go in a different order, just a little bit different here. What's changing or what did change? What's new in 2022? In our January ballot, we had added what we call submit attachment operation. And this allows providers and others to be able to submit documentation to the payers in a solicited or an unsolicited transaction document. So it could be a requested document, or it could be just something the provider knows that the payer is going to request from us in the future, so they know those instances and they will send those documents to us. That was the January ballot. Then we also had a ballot in September where we added a FHIR-based approach for requesting attachments. So this is a CDEX task attachment request profile, and this is for both claims and prior authorizations from a provider. That is where, the payers today will request something from a provider, again, maybe to support a claim, missing data, or we need something that was missing in the prior auth that they sent us. So we'll ask for that documentation. We tested this at the last Connectathon in September. Going now to getting involved. We are also under ballot reconciliation at this time. The September ballot is STU 2.0, and that's ongoing right now. So we've got, yes, please read and review this publication. And again, we would like to have some more folks join us at the Connectathon in January. Some of the things around CDEX, also what we do, requesters can be very explicit when we're talking about when we're requesting an attachment. That's, we can ask for a condition, a medication, an observation resource, and we can be very specific using link codes for, what type of document or lab information that we need. That's being used today in today's world too when we ask for documents from our provider community. So that's also built into CDEX. It also provides a mechanism for workflow on the provider side that allows human intervention from a task, because a lot of times when we will ask for something from a provider, they have to go pull that document and then send it to us. But we also have the query approach too with other processes where we may be able to automate the completion of a request. So what we're looking ahead to right now, again, we're seeking participants for our January Connectathon. We'd love to see some more providers and payers and EMR systems to help us with testing in January. Our meetings are on Wednesday for CDEX at 2 p.m. Eastern time, and we'd love for others to join us. We're doing some reconciliation at that meeting right now too, but we also are prepping for the Connectathon, putting together, our reference implementation and new testing scenarios. One other thing we're looking at is we're expecting a regulation to support CDEX in the near future. There has been something out on the unified agenda for many, many years around electronic attachments, and I've included that publication that came out in the spring that talks about the standard adoption under admin SIMP for healthcare claims attachments, electronic signatures, and some other information around referral certification and authorization standards. So for us, we know right now, talking to the OMB, which is the Office of Management and Budget, they have this right now. They're a little backlog, but they will be reviewing this. And again, we're hoping that something will be coming out early in 2023. And really the rule proposes providers to support both healthcare claims and prior authorizations and the standard electronic signatures to be used in conjunction with the healthcare attachment transactions. And we've really built CDEX to do all those different processes. So I'd love to see more people involved with us. We know people are wanting to see this come to fruition. As Vanessa had mentioned earlier, there's a lot of interest in CDEX. So please come join us. Let us know if you want to help us at the Connect-a-thon. We'd love that. Again, we also have the CDEX Confluence page listed here below, and we do have the current build, the CDEX STU 2.0, the one that's been validated in September, that you can go to and get more information. I think we can go to the next slide, Vanessa. Thank you. So now we're at PDEX, or the Payer Data Exchange. This PDEX enables a health plan to share key clinical data with patient history, with applications of the patient's choice, and with other payers. So there has been some rules that have been dropped. One was the patient access final rule for CMS interoperability. The enforcement began July 1st, 2021. And this is to, allow patients to have their data available via patient access API. So many of us are doing that today as payers. The other piece on payer-to-payer data exchange, there was a rule that was effective January 1st, 2022. This enforcement has been deferred, and I know we were talking a little bit about this before, covering the AEOB GFE information. Oh no, sorry, not on this one. Payer-to-payer data exchange enforcement was deferred. This is where we're sharing our member data. A member will request, say, a previous insurance carrier or payer that they have moved to a new payer, and that payer now will have to share 5 years worth of data on that member, the historical data that we've captured. Payer-to-payer, again, data exchange. There is quite a few of payers that are doing this today. We're not getting many requests, but we are still working to really onboard multiple payers. So this is still ongoing. Again, enforcement is deferred, but it hasn't stopped the work that the payers are doing today to have connectivity between each other. So in addition, we had in what changed or what was added in 2022, the addition of a prior authorization profile based on explanation of benefits resource was added. Also for the payer-to-payer business exchange flow for members exchange. We also have other related IGs that Vanessa had alluded to earlier. They are part of PDEX. So there's the PDEX formulary published in August. It includes significant structural changes and updates to search. And then PDEX directory PlanNet that was also mentioned earlier. That version is 1.10. It was published in April and includes support for status, active changes, and providers needed for the No Surprises Act. Outside of their facility, and this will help facilitate the providers in getting that information.
All right, looks like we ran into a little bit of technical issue with Christol's bandwidth. So we're going to go ahead and let's go to the next screen. And if we can get her back, then she can finish up her slide.
Next on, there are some prep sessions happening on the Friday. That's the PDEX call. And something jumped.
We were having, you froze for a little
Thank you.
bit, but I think we're good. Keep
And
going.
again, read and review the public. Oh, okay. And we want people to adopt and pick up the IG. I know a lot of people are actually working on the payer-to-payer right now. So payer-to-payer, looking ahead, bulk data exchange. Tell me, you know, all about my patients, leveraging ATR export for member attribution and attribution IG. Also transitioning from MTLS and the OAuth 2 to the fast UDAP for client credentials, request and issuance. So with that, again, you can have the more information found on the PDEX homepage. You see the PDEX Confluence link, and then the current version of PDEX. Also, we gave you a link to that IG. And with that, Vanessa, I will turn it back over.
Awesome. Thanks, Christol. We lost you for a hot minute there, so I just want to say what I think we might have missed was the read and review and finalize for publication. We're pretty close to that publication point, so it's a good opportunity to pick up the PDEX guide and have a look at it before we publish the next iteration. Was there anything else you wanted to add on the getting involved pieces? We might have missed what you said.
Yeah, I don't know where I cut off. I'm not sure.
That's okay. I think you covered most of it, so we're probably good to move on. Thank you so much, Christol. That was great. Awesome.
Thank you.
All right, Linda, if you want to come on for a risk adjustment, you should see that slide now.
Hey, hi everybody. I apologize for my voice. First of all, I jokingly said Vanessa sounded like this on Monday, and it was contagious over the phone call. I think they're going to find that someday, but apologies for the voice. So I'm very excited to be involved in this risk adjustment use case. I started working with Yen Harris, who's just a powerhouse, and really great team that's working on this. So when we say risk adjustment, we mean what you most commonly probably know as HCC the category condition codes or the revenue normalization. And as you may recall, we started out this process with creating a report. So it was how all payers, hopefully, could consistently send a report to the provider for a single member, or we showed how to use it also with the ATR member report. And then once they get that report, they would look at it, and that's where we left off with our version 1, which got published earlier this year. I believe it was in May. And then we went on and started looking at, okay, they have the report. Now we need to remediate and deal with the issues that when the report is received, I know this will surprise all the providers on the call, but sometimes they're not exactly correct, right? So it needs to be a way that you can actually respond to that report and indicate the concerns, or if you have data that could close one of those risk gaps, that you could include it and send it back to the payer. So that's the process we've been working on for our second guide, which we hope to go to ballot in January. So far, so good. And as part of that, we were really excited to be involved in the CMS Connect-a-thon this year. And we showed a proof of concept that somewhat aligns with or looks a lot like quality measures. We use CQL to represent a very simple risk adjustment to look for condition category codes and any excluded conditions, etc. It's got a long way to go. We certainly have to work with CMS and see how we can make that work as we move forward, but we're calling them the digital condition codes. And in our IG that we're working on right now, and we'll go to ballot, it will have an example of what that is and how to use it from our initial work that we presented in July. So very excited there. And what you should pick up from that is this use case, the next one I'm going to talk about, as well as the one that Dave talked about, all use CQL. So you should have people learning CQL in your organization. And we have lots of ways to help you do that. And then what our ballot will do is we've actually are adding some operations. We are modifying slightly how we generate the report. and it accommodates for how we now will do remediation. So there will be for those of you who know FHIR, detected issue added. There'll be an operation that can be run. It will update that bundle and send it back to the payer or their HCC coder, and then have them look at the data that's contained, and it's sort of this back and forth remediate between the provider and the payer until the issues are resolved. And then we can reconcile that and update it at the payer site so that the report will be updated. Might sound very familiar. On the next slide, I'll talk a little more about why it sounds familiar. So we're hoping that you will vote and comment. Of course, you know, as we get near the voting time period, you're welcome to look at any time and log trackers. It doesn't have to wait until the voting cycle. Even if you're not a voter, you can still log JIRA trackers and comment, and we really hope that you will. We have some people that we believe will work with us on testing in the Connect-a-thon in January, and we hope you will consider that or talk to the people that are involved with risk adjustment in your organization and have them start participating. Join now. We have links down below. You can see that for the risk meetings. And then we have our build, our continuous build on the right-hand side. We link to the continuous build as opposed to the published build because we're doing a lot of work there right now. Once we get this out, of course, we'll reconcile those comments and then publish the version, hopefully version 2. And we do intend to do an additional IG in 2023. Now's your chance to join and start thinking about what those things might be that you want to see added, updated, changed in that 2023 version. And with that, if we can go to the next slide. This slide is near and dear to my heart because any of you that were with us back in the beginning know that this arose out of one of our very first use cases back in 2018. It started with thinking we had to do medication reconciliation post-discharge, and it was really hard to get that and get a claim with it in the 30 days. As we worked on it, we were really fortunate to get tied into the CQI group at HL7, Clinical Quality Information, and they said, oh, we really need this, but wait, it's not just for that one instance, it's for all of the quality measures. We need a way to exchange data using FHIR. So our very first IG created a way that you could create a measure report and attach data you had for quality measures to report quality data. And then we found out that there are organizations that actually have to do what's called now a QRDA Category 1, which is an individual measure report, typically hospitals, for their quality reporting. So in our later version, we added the ability to do individual measure reports, QRDA Category 1, and as well as QRDA Category 3 reports in the IG. It shows you how to do that. And then last but certainly not least was sort of where we started with the risk adjustment. We created the Gaps in Care Quality Report. So that report can be generated and sent to a provider. And with all of these reports, the goals are consistency, right? We don't want payers to generate 1,000 different quality reports, and we certainly don't want providers to have to consume those. So this gives one standard way of communicating quality gaps that the provider believes they have or perceives, and then once they receive that, they can use the data exchange measure report to send back data they have. There are very common scenarios here, and I'm sure any of you work in quality know those. The patient changes payers more frequently than they get colonoscopies, right? So it is likely that a provider may have a colonoscopy on their patient that a payer doesn't yet have. So they can exchange that data with the payer using the data exchange measure report and close the gap. And in our IG, we show how that is done. There's a great example of showing exactly that for the colonoscopy measure report. The really exciting news for me for this group is it's the first one we've been able to hand back to the community. So we started this work, and then we talked with the people that are working on quality measures. We're one part of it. We're reporting, but any of you involved in quality know there's guides around how to do the measures. There's the QI core guide, and there's a community that was very open to picking this up and supporting it. So yes, we still attend. I'm on almost every call and asking probably just as hard of questions as I ever asked. But it's community owned, and that's really where the effort we want to have happen with all of our use cases, that it will be continued, adopted, and supported by the community. So we are updating right now just a sort of an errata STU update on this with some cleanup and corrections that we need to do. But we're going to go to full ballot again in January. And in that ballot, probably the most significant part of that ballot will be that we are adding a guidance response. You don't have to know what that resource is. What it means, though, is now within this report, it will give you a very clear way of identifying what needs to be done to close the gap. So it will give you the value set of CPT codes and with what date range we'll need to close that particular gap. So that is being worked on and will be added to this guide. And we still have our meetings. They are bi-weekly. You can see that on Confluence. Down at the bottom is the link. And then we also, you can look at the continuous integration build. We link you there because we're doing a lot of work at the moment there. And I mentioned earlier, this guide uses QI core, the clinical quality framework quality measures, as well as CQL. Again, another reason to learn and start to educate your team around CQL. It's a great group to work with. They're a great group of professionals. They do a lot of really hard work trying to make measure reports work and work in a way that they're computable and that you don't have to worry so much. If you can get the data in FHIR, US Core covers a lot of quality data, people. I think it's somewhere between 70 and 75% of US Core. It equates to all of the things in quality in QI Core. And you're going to be getting those, right, with your EMRs by the end of the year. So using FHIR as it comes out of an EMR and using these CQL measures that are written on FHIR, you don't have to translate the HQMF that comes out from the measure authors. You can actually just run it all natively in FHIR, and you won't have any of those, as I call it, lost in translation moments, where you read something in it and implement it one way, and CMS or ONC, I'm sorry, one of the measure authors thinks it's different than that. And so this will really make a huge step forward, and we really hope you will come look at this, adopt it, join our DEQM calls and also the clinical quality information calls on Friday from HL7. I'm also happy if anybody wants to reach out to me with any questions. Always happy to help. Want to get this implemented. I made it, Vanessa.
Linda, that was awesome. Thank you so much. I'll pop on screen here. That was so great, Linda. Thank you so much. And we are really excited to have kind of launched our DEQM Gaps in Care Guide to college, if you will, and back into the community for support. It's very exciting. Well done, team, and thank you to all of you who participated in that. This slide is a quick summary of the schedule of all those public calls that were mentioned by our speakers today. So the new calls are noted here, and we mentioned them. These are links to the HL7 conference call calendar, which is on the HL7 website. So you can check that calendar for cancellations or changes. That's really our source of truth. We have some instructions on our Confluence page for Da Vinci on how to get that signed up and get those calls to your own calendar. There's no invitation, so you go to this link and then you add the invite to your own calendar. If you ever have any questions, you can always reach out to us, DaVinciPMO@POCP.com. And as Linda mentioned, we included the use case confluence pages, and there's also some information on the schedule and the login there as well. So you can always check that out. But we wanted to make sure that these links were available for everyone. And with that, I forget, Alex, if you're covering this one or I am. Should I keep going?
Please cover the slide.
Yeah, I think it is me. I apologize.
No worries.
We also created, I think I created this slide as a public Confluence resources. So we have a ton of stuff out on Confluence that's publicly available. You can sign up, request an account. There's a link here to request an account for HL7 Jira Confluence. They're free. They're available to anyone, even non-members, non-HL7 members. You just fill out a quick form and then they set you up with access. And there's a whole Da Vinci space that has public resources. There's a Da Vinci welcome page that is a Confluence page to learn about the project. You can sign up for our listserv if you're interested, and that's the screenshot that's here, this join listserv on welcome page. It's teeny tiny text here. But you can check that out and stay up to date with what's happening. We also created this, we have two really great resources. One is a implementation guide dashboard that's a big dashboard grid that goes through all of our guides and has a ton of really great links about them all and information about them, including status updates at a high level so you can keep track of what's going on. We also created a year or more ago now a implementer resource page. So it was meant to be if you're new to Da Vinci, but honestly, it's really if you're new to FHIR or new to this whole sort of standards HL7 FHIR world, and it has links kind of about how to get oriented and where to get started and what all this means. And we tried to orchestrate it in a few different ways for different audiences. So there's like a section for developers, a section for business analysts, a section for just general information, and then there's a section on like if you're trying to get into Da Vinci and understand how do I solve this business problem, what implementation guides are relevant for it. They're kind of linked that way in a grid. So it's a really great resource that we probably should do a better job promoting. So we encourage you to check out that implementer resource page. And then Da Vinci use cases, this is our parent page to a lot of those use case Confluence pages that were mentioned by the other speakers today. It's got the information on all the meeting minutes and other use case materials that you can reference. It's actually right in here, if you can see my screen or my cursor. Right in there in our list here. And then the last important link to point out is that, of course, our Da Vinci video presentations, which is how you would gain access to this recording and past recordings to our community roundtable and a lot more of our videos, which is a space shortcut right at the top here, but it's also available within these pages under the calendar, I believe. So there's the quick links over here. We always try to post our latest and greatest kind of master deck. So our birds of a feather deck from the most recent work group meeting we'll post, which gives more of an overview for newcomers on all of our use cases. That sort of 1 slide or 2 slide summary of each use case, if you're brand new, can be found in that deck. And also a number of other of the links that I just mentioned. So we encourage you to get involved and check out all these resources and join us and have your voice heard on these standards. So thank you. With that, I will turn it over to Alex for Q&A.
Yes, and please stay with me, Vanessa. I invite the rest of the presenters to come on screen. Thank everybody for such an awesome delivery, despite a number of technical glitches we've had today, whether you've seen them or not. I want to do a shout out to the terrific confidence and content presentation from our presenters today. So I'm going to start out with some questions from we've gotten from the audience. Encourage everyone to go ahead and submit their questions in. Linda, I'm going to ask you to take on the first question regarding TEFCA. So the TEFCA RCE, or the Recognized Coordinating Entity, RCE, recently published their draft TEFCA Facilitated FHIR Implementation Guide. And you'd like this audience member would like some comment on the significance of the TEFCA exchange to the Da Vinci community and the opportunities thus it may provide to accelerate or incentivize the use of Da Vinci IGs. You want to come off mute for me? Thanks.
Sorry about that. So certainly we're all about FHIR. So until that IG came out, the TEFCA was all based around the XCA cross community standards. So we're definitely watching what's happening there. As the questioner mentioned, it just came out a couple weeks ago. I went through it yesterday, and there is a lot around security that I hand off to people that are much smarter on security than I am to make sure all that will work. The first version is a facilitated version, which means you still have to use some of the cross-community work to find out where the patient has data, and then once you find their endpoint, you can do the FHIR communication. So it's the beginning, and we certainly want to see it move forward. I certainly don't represent the RCE in any way, but I know from all of their meetings that they have been talking about their work they're doing. They had a listening session, which I listened to yesterday as well, around payment and healthcare operations. So they are looking to publish an SOP around that the beginning of next year. And that will be really important for any payer constituents that we have that need data for those purposes.
Thank you very much. Any of our other presenters have some commentary on that? I'd encourage everyone to think about not only the TEFCA FHIR IG that they're releasing, but to think about that endpoint discovery point that Linda made as it ties back to the National Healthcare Directory and really helping to make FHIR exchanges easier to get to a scalable and more ubiquitous manner by having such a directory. So some things for us to think about as we start to move forward with modernizing some of our capacity for information exchange using API technologies. So I'm going to ask a question to all of our presenters. So if Christol, I know you may have had some bandwidth issues, but maybe you can still join us at least on audio if you don't feel comfortable with your video. But I think everybody will have some perspectives that may be useful to our attendees. As you come into the Da Vinci community, and we are all about fostering community and teamwork, bringing the best and the brightest together to lean in and offer their experiences so that we can develop implementation specifications that come to life in a way through the software that folks end up building that enables us to really accomplish the value, the reduced burden, the increased information exchange, and related other opportunities. But if you're starting to think about getting engaged in the Da Vinci community, it might be helpful to hear from you all about how do you bring your business and your technical resources from inside your organizations into the use case calls. So what I'm interested to learn from you is, one, do you bring technical? Do you bring business? Do you do both? And if you're going to bring resources in, how would you set them up for success to come into a use case? Because we have a diversity of use case maturity statuses. So some are very new and you can get it on the ground level, where other ones are more advanced. So maybe we'll start with you, Vanessa, and then have others add into some commentary.
Sure, happy to. I think that there's an opportunity as the use cases flow in different phases. There is different times where different resources would get involved, right? And so, early on in a use case, like for example, with value-based performance reporting. There's a lot of more business folks involved in the use cases, business analysts, other product leaders that are looking to shape how the scope of the use case is going to go, what the IG should cover, things like that. And then as we get sort of past ballot and more of ballot reconciliation, there's going to be more technical discussion and need for some of those technical resources. I think there's always an opportunity for technical resources to be involved and stay abreast of what's going on, particularly if you have an eye on implementation and starting to get into some of those details.
Others want to comment on how to bring your team into the fold and have them feel like they're contributing as well as learning?
Yeah, I can speak. Can you hear me okay, Alex?
Okay, you're very clear, Christol. Go for it.
Okay, great, because it is a little wonky in my system right now.
Okay.
We have quite a large group of associates that are involved in different pieces within Da Vinci, but I think what was very helpful is with Da Vinci and their project management office, even when new projects come out, and when we first started Da Vinci as a accelerator and before, we would have the PMO also come in and speak to us on what these different use cases were. It was very helpful for us to get buy-in from multiple areas, which you need. I mean, from our perspective, we have business, we have IT folks, we include our public policy, our legal, and we have multiple different people from different teams working on different IGs. So it's been a very welcoming community, I'd say. We get our questions answered when we have questions. So I think the whole Da Vinci group, or we call it a village sometimes, the village has been very great for working with not only payers, but providers and other companies to really show them where we're going, the vision we have, and including us to be building that vision and supporting others. So yeah, I think it's been great. And again, we have many folks across the board in Elevance that's involved in many IGs.
But it sounds like you really gave them a level of support, either directly or from the project management team within the Da Vinci project to really help orient. So it sounds like you also had to go through a process of getting your bearings, figuring out what use cases you cared about, and then figuring out who within your own internal village may want to get engaged, and that it sometimes was technical and it was also business folks that you wanted to bring to bear. Okay.
Correct.
Awesome. So Dave or Linda, do you have any thoughts on bringing people into the fold and helping them feel productive?
Sure. So personally, Cambia started this FHIR journey back in 2015 and started very grassroots, side of the desk. Few people that could see the value in FHIR and what was being built there, really evangelizing that across our organization. But it's different now because now we have FHIR IGs named in regulation that are forcing people to pay attention to these use cases. I would say connectathons are a great way to get your development people involved. Looking at and understanding the reference implementations, engaging in the weekly calls to help drive the direction. Business expertise is always needed on those calls. There's always questions that the techie FHIR people just don't know the answers to because they're business experts and they're needed there. Earlier the use cases, more they're needed, but always appreciated.
Yeah, and I think that's one of the biggest challenges, Dave, I have is to convince people that are business me's that they can participate and that they're needed. Well, I don't know FHIR, it's like this. And you don't need to, trust me. There are people on the calls that know FHIR. It's much more those business me's that make a difference, especially in the beginning. We wouldn't be where we are today with the EQM without Jenny from Blue Cross Blue Shield of Alabama. We wouldn't be where we are today with risk adjustment without Brent Zenobia. from Novelis. You know, those business experts came in and they helped us draw that bridge between the use cases. So encourage those people. And I also believe once the business is involved and understands what we're trying to do, it helps them facilitate getting the engineering staff involved. Because if the business doesn't buy in, they're typically the ones that give us the resources to allow us to participate on the engineering side of the world. So definitely bring your engineering people in. I'm sorry, bring your business people in, and don't let them be intimidated.
Well, and I really like that point. You know, I know when I was working in Medicare Part B very many years ago as a business operations person working in the provider credentialing space, I got into the X12 world, and it was that rolling up the sleeves, working with the data to figure out how it was going to work and with the real world ins and outs of systems and compliance obligations that made that standards involvement all that much more robust. And I think that one of the things I really want to point back to is Vanessa's comment on the implementer support page. So I think that if you look at the implementer support page, it's got some basics that at the top, and then it works down through developer perspectives, business analyst perspectives. But it also then gives you kind of a framework for thinking about what you need to get your arms around. The second piece that I think is important is that when Vanessa talked about the use case supporting materials and the meeting materials, you can see the history from the meeting minutes. They're all publicly available. You don't have to have a login to get to it, but it does help if you have Confluence credentials if you want to play in the community, because it is a collaborative community. And so I think what's important for me to also highlight is that I think sometimes the business folks think they don't need to be over there with the standards development folks, but it's that marriage of technologists with operations folks that really bring the finer details into those specifications that really make the difference in our ability to reduce burden and bring value through technology and automation. So I want people to feel that there is a community that they can get into, and also to know that on that landing page for the use cases, you'll find a list of the leads, like the leads you've all met today, that you can read. Their emails are there. You can reach out to them and ask, how do I get engaged? How do I get up to speed? What's the best approach for me to take at the position I'm in within my organization to start to jump into the deep end of the pool on the implementation guides? So that's a little shout out for folks to participate there. And I'd like to build on that with one last piece for comments about how do you get into that testing, connect-a-thon environment that we're really, that HL7 has really leaned hard into to make sure that we're testing our implementation guides before they get named or as they're getting named into regulations. So any thoughts there on how folks can get better prepared to play in the testing arena? Vanessa or Dave or anyone want to start?
I'll jump in there. So two things. One, just on the last topic, I just want to reiterate the importance and that I recognize that it can be really intimidating for organizations to try to determine where to begin when now we have upwards of 15 different use cases, and that's just within Da Vinci, not even looking at all the other accelerators and opportunities to leverage FHIR for business challenges. And so the first thing, if you're at that stage, is to really sit within your organization and think about what those sort of corporate enterprise-wide goals are, what you're committed to trying to achieve this year within your own organization and your broader community, and then look at what use cases are out there, what standards you can leverage to try to meet those business needs. And it may be more than one use case. You know, these IGs are meant to be building blocks that work together. So I just wanted to add that piece as you're starting to dig in. To get to Alex's question now, and I'm sorry I jumped backwards on you. Testing. I loved that on Dave's slides. I think it could have been on all of our slides. There are HL7 Connect-a-thon events 3 times a year, and usually another one in the summer that is a CMS HL7 joint effort. I think we try to do a lot of promotion of these events on the HL7 side and also within Da Vinci community. But we encourage you to get involved now as we're approaching the January Connectathon. You know, we're starting to build out, the lead core teams are starting to build out what that testing focus is going to be. And you can be a part of that as this community. If you have a piece of code, even if it's not a full-blown solution, a piece of code, something somewhere, a server, right? You play one piece of it, we will help partner and pair you up so that you can test your one piece or your whole solution. We do that a lot. And that's what we're here to do. We want to try to get full coverage of these tests. We learn as you're learning too, as a whole community. So we really encourage you all to get involved there. We also are happy to work with you on the weekly calls. If there's a use case that has sort of a lull, we may be able to use that weekly call time to do some testing. You know, we're pretty open to that kind of stuff as long as we have advance notice on what the agendas are going to be. So we strongly encourage you to get involved with us in the planning early on for those Connectathons as well. And I'll let some of the other speakers talk.
And Vanessa, I was going to say too, just so people are aware, you know, even people from the business side that may not be doing the coding, you know, really should be joining. You know, I started out going to Connectathons, gosh, I don't know how long ago, but being an observer. So it's not like you have to be there and do the testing. You are learning so much about the work that's being done in the industry, what's coming down the pipe by just being there, moving around to different, you know, tables, to different, we call them tracks for the IGs. But I would really recommend highly that some of your business folks also come and understand, or even some of your maybe new digital IT folks too. They may not have the code right now, but they'll be jumping in saying, oh, I get it, and let's get involved in this. So coming as an observer, I just wanted to throw that out there is very, very good use of your time.
And I would like to offer, there's an intermediate there too. And we have a number of test cases that we build using the Aegis Touchstone for every Connectathon. You can join and run those test cases. You can also join and look at the example data. We had a really awesome participant who went through and reviewed all of our example data for us during a Connectathon and told us what was wrong. And sometimes when you develop these within a group, you don't see the obvious stuff, and it was so helpful. So you can be there and do hands-on work, even if you don't yet have that reference implementation.
I'd like to add, a lot of these use cases are solving common business problems that everybody has. And finding a partner like Vanessa mentioned, where we can maybe bring up a skeleton code to where you can demonstrate as a developer to the business people how these IGs can solve our common problems. That's kind of a form of testing, isn't it, Alex?
All right, so folks, we are at our time, unfortunately. I know we could have lots more discussion. I'm going to give everybody, anybody has any final parting words before we wrap it for today?
Engage the community.
Yeah, it is a community. You are welcome. You will feel lost and maybe a little overwhelmed at first, but we all started someplace. You just got to take the first step, and we welcome you to join us as we all try to improve healthcare for those that we love, including ourselves, and to have an overall better set of standards in interoperability. So with that final word, please have a great rest of your day, and thank you for joining us. We'll see you November 30th for our final roundtable of 2022. Take care.
Thanks, everyone.
Bye, guys.
Good seeing y'all.
Thank you. Awesome. Great work.